Welcome to our second WFI meeting in Athens. I've done this talk many times with the idea to show some of the follicle characteristics that can be useful for a FUE surgeon. We all know what's a follicular unit: 1 to 4 terminal hairs, up to 9 sebaceous glands, the erector pili muscle, the perifollicular vascular and neural plexus, and perifollicular tissue. This description can be useful in FUT when you split the units under the microscope vision, but in FUE, our only reference is the hair that comes out from the scalp. It's a totally blind method. That means that when we attempt to extract a graft, we must take in account many other known factors as hair caliber, color, texture, angle of insertion, depth, and the most important and key of this talk, the follicular adherence. We define the follicular adherence as the structures that impede the extraction of the follicular unit from the surrounding tissue. In other words, the anchor system that ties the unit and must be cut in order to liberate the graft. Why is so important for me? I will try to explain. One of the frequent questions students or beginners do is: how deep do you penetrate with your punch? 2-3 millimeters? The answer is, there is an ideal depth of cuts, different in all patients, that we must determine at the beginning of the surgery. So, the right question is, which are the structures we must cut in order to liberate the follicular unit? Answer must take into account both diameters of the unit, sagittal and longitudinal. The right sagittal cut is selected by the punch diameter. The gap in between hairs for a normal 70 units per square centimeters density is 1.1 to 1.2 millimeters. But if we see a transversal sample of the follicle in a microscope, we observe that the hair is never located in the center of the unit. That means that as much as we open the diameter of our punch, the more we can make damage to the surrounding follicles, increasing the risk of depletion. In conclusion, we can use the same punch for all patients. We must use the right diameter for that particular patient. If we do a sagittal cut at different levels, we observe that in the upper part, all the units are close together with little intercellular tissue. In the mid part, at the level of the display and bulge, the sebaceous glands disappears and there is more tissue among them. In the lower part, all roots are independent with their own outer sheath. When we attend to the longitudinal cuts, we confirm that the longitudinal structure of the follicle is not regular either. In the upper segment, the external limit is the sebaceous gland, the width part, with an average of 0.9 millimeters. The lower part has a smaller diameter depending on the number of hairs. To study the anchor system, in 2007, we did a study sending graft samples to our pathologist at different depths of cuts. After the analysis of those samples, our conclusions were: the follicular adherence is determined first by the sebaceous gland, and with less important by the erector pili muscle. In the inferior part, the fibrous sheath that wraps the follicles is not attached to the surrounding tissue, so we can pull and extract a healthy graft once the adherence of the superior segment has been cut off. For that reason, the best level of cut must reach the inferior part of the sebaceous gland and cannot overpass the insertion of the erector pili. The greater the depth of cuts, more possibilities to transect the inferior roots. 95% of the partial transections are always below the sebaceous gland. As bigger the longitudinal diameter of the sebaceous gland, deeper the penetration of our punch in the tissue, increasing technical issues. We always peel and leave part of the sebaceous gland in the field with our punch, but this issue don't have any influence in the survival of the graft. Lastly, this is obviously valid for most of our virgin patients. Previous procedure or skin disease can lead in connective attachments of the outer sheath to the surrounding tissue. In summary, the ideal incision depth should overpass the sebaceous gland and reach the insertion of the erector pili, but not further. That's very important when we deal with curly hair. Exerting a small traction force on the skin with our forceps, we can liberate the graft, breaking the last unions of muscle fibers or tissue still attached. Increasing the depth of penetration will facilitate extraction but will augment the risk of transection. On the opposite, more superficial cuts would leave part of the sebaceous gland undivided. More traction will be needed, with more trauma that lead on broken follicles or capping. This knowledge is especially useful in particular cases as the Afro-American curly hair and VHT. In curly hair, the superior part of the follicle is always straight, due that the sebaceous gland gives the structural support, and it's only after the isthmus when the follicle, free of covering, takes its curly shape. So, with an accurate measurement of the gland longitude, we can achieve the right depth. Next, with a precise movement of both forceps, moving the hand in the same direction of the curl's curve, we can break the remaining attachment and the graft will be liberated. The hair of the beard is also curly, but is thicker and longer than the scalp hair. Luckily, has a short sebaceous gland, so we don't need to penetrate deep enough to cut their follicular adherences. The same rotational movement with both forceps to the liver will give us healthy grafts. Thank you very much.